Please join me in reviewing a very important seminal publication entitled The Chiropractic Hospital-Based Interventions Research Outcomes Study, a randomized controlled trial on the effectiveness of clinical practice guidelines in the medical and chiropractic management of patients with acute mechanical low back pain. The study was published in October of 2010 in the Spine Journal and was awarded the 2010 Outstanding Paper in the category of Medical and Interventional Science. The primary authors are Paul Bishop, Jeffrey Kwan, Charles Fisher, and Marcel Dvorak. Participating chiropractors were David Olson, Brad Yee, Don Nixdorf, and Heather Hoskins. This study was coordinated and conducted in Canada at the Spine Specialty Center Outpatient Clinic at Vancouver General Hospital. Using a medical physician as a gatekeeper for matching of patients with inclusion-exclusion criteria, patients who were referred to the Spine Center with acute low back pain who met the inclusion criteria were randomized into one of two groups based on block randomization. The inclusion criteria were based on the categorical system developed by the Quebec Task Force for acute mechanical low back pain of 2 to 4 weeks duration, categories 1 and 2. Now, this includes patients with low back pain only or pain with radiation to the lower limb proximally, but not distally, and does not include patients with neurological signs. Both men and women were included ages 19 to 65. Exclusion criteria included some obvious non-mechanical or complicating problems such as tumor, infection, fracture, etc., but also comorbidities that the authors considered contraindications for spinal manipulative therapy. Keep in mind that this study, in fact, uses a standard chiropractic side posture, high-velocity, low-amplitude procedure, and the authors are simply limiting the patient type based on this procedure, not all chiropractic procedures. These comorbidities included spinal nerve root irritation, pregnancy, prior surgery, other spinal pain, meaning other regions, and third-party insurance claims. The two groups were the usual care group and the clinical practice guidelines care group. Usual care consisted of family medical physician care for acute low back pain, which was left entirely to the discretion of the MD, and could include care by physiotherapists, kinesiologists, or manual therapists, and certainly included prescription opioids. Clinical practice guidelines care was delivered by chiropractors in the outpatient facility of the Spine Center. We will discuss the guidelines in a moment. The primary outcome measure was the familiar Roland Morris Disability Questionnaire at 16 weeks, evaluating whether there was a minimal clinically important difference in scores. Secondary measures were the Roland Morris at 8 and 24 weeks, and the short form 36 or SF36 measure of bodily pain and physical functioning domain scores at 8, 16, and 24 weeks. Now, in a sense, two things are being captured here. One is, how well did each group do on these primary and secondary outcome measures, and was there a significant difference between groups in their outcomes? The authors note that the 16-week time point for the primary measurement was chosen because this ends the acute phase and is often a predictor of chronicity, if no significant change has occurred at this point in management. The clinical practice guidelines are an amalgam of acute low back pain guidelines, including the HCPR guidelines here in the U.S., the Royal College of General Practitioners guidelines from the U.K., the Australian National Health and Medical Research guidelines, among others. The guidelines include reassurance regarding the natural history of acute mechanical low back pain, avoiding passive treatment approaches, advice to carry out a progressive walking program, specifically 2 walks a day, each between 5 to 15 minutes based on patient tolerance, and increasing that time by 2 minutes each walk per week. Acetaminophen, 650 milligrams every 6 to 8 hours, as required for 2 to 4 weeks. Now, this one may surprise some chiropractors given some scope of practice limits in some states in the U.S. as to what can be said to the patient regarding even over-the-counter meds, but it's clearly allowed here and in fact recommended in some guidelines. Continuing with the guideline recommended treatment, they included conventional chiropractic side posture adjusting performed by chiropractors for a maximum of 4 weeks, 2 to 3 times per week, and if applicable, return to work within 8 weeks. You can see the heavy emphasis on early function, avoiding too much rest, and avoidance of becoming reliant on passive therapies, including manipulation. So what happened? The outcome was a mean improvement in the Roland Morris scores that were significantly greater in the guideline-based or chiropractic managed treatment group versus the standard care treatment group with a significant p-value of 0.003. So here's where we need to tease out several points. The minimal clinically important difference was designated in this study as 2 to 3 points change in the Roland Morris, which is acceptable. However, some have recommended a range of 3 to 5 points for the MCID or a percentage change of 30%. Well, we'll see why the researchers chose the 2 to 3 point threshold in a moment. First, let's review the Roland Morris questionnaire and some of the variations in the description of a minimal clinically important difference. Now, this is a 24-item questionnaire that has been shown to be equally reliable and responsive when done as a paper or an online form. The patient instructions are to check the descriptions that match your back pain for today and leave blank any statements that do not match your back pain today. Some examples are, because of my back, I am not doing any of the jobs I usually do around the house. I use a handrail to get upstairs. I lie down to rest more often. I try to get others to do things for me. I'm more irritable or bad-tempered with people than usual. Or I stay in bed most of the time because of my back, etc. The higher the score, the more severely the patient is affected. Scores above 20 or below 4 require percentage change to indicate significance. Now, intermediate scores at baseline, such as in this study, that were around 12 to 13 points for both groups, are in the range of 2 to 3 points in a minimal clinically important difference, and it fits pretty well in matching a percentage change that is considered clinically significant. What we don't know that would be interesting is that given the standard deviation was about 5 to 6 points for both groups, what if those in the lower range, say 7 to 8 points, had changes of 4 points, and that'd be a 50% change, while those in the higher range, say 17 to 18 points, only had a 1 to 2 point change? The average would still be about 3 points, which would hide the fact that those with lower scores had some significant improvement while those with the higher baseline scores did not. Or vice versa, where those with the higher scores had on average bigger changes while those with the lowest had the smaller change. This could all still average into the same change of about 3 points, but we could not know the specifics of which group was affected the most or the least. The improvement seen on the primary measure of the Roland Morris at 16 weeks was a statistically and clinically significant difference for the chiropractically managed patients compared to the medically managed group. And separately, the usual care group, the medically managed group, showed very little change. With that, one worries about the potential for this group to go on to chronic, costly management. For the secondary measures, the 95% confidence intervals and p-values do not reach statistical significance. Translated, this means that statistically one can't conclude that there is a difference between groups on these secondary measures. The authors do note that one reason for this may be the fact that the vast majority of usual care patients were still taking opioids, which may have influenced their responses. The researchers also used a guideline concordance score with a maximum value of 7. This guideline concordance score was developed and utilized in a previous publication by Bishop et al., which interestingly enough demonstrated the difficulty in getting primary care MDs to follow guideline-directed care recommendations. Used in this study, there was an attempt to determine if doctors in the medical usual care group provided management recommendations anywhere near those used in the guideline-directed group, even though that was not a requirement. It turned out that the highest score achieved in the usual care group was a 4 out of 7, with 77% scoring only a 2 out of 7. This was based on each patient's recommendations from the doctor. There's an editorial insert in this article which is telling. They point out that the rates of opioid use was 80% and still 77% at the 24-week measurement in the usual care group, and that passive modalities were prescribed 60% of the time in this group. They state that following guidelines may in fact not only provide better patient care, but also minimize costs. These costs would include the decrease in prescription of expensive medications, but also the decreased costs created by chronic low back pain sufferers, which include lost time at work, etc. This study was executed well and hopefully establishes the groundwork for future studies in various practice settings, including managed care settings in the U.S. It's important for chiropractors to understand that the clinical guidelines are including manipulation as only one aspect of the total care plan. Educating patients regarding the natural history of acute mechanical low back pain is important, and encouraging early activity, especially walking, are crucial to the success of this approach and should be part of the management of acute low back pain for all healthcare practitioners. What we bring is unique to this guideline approach, the chiropractic adjustment, but it should not be used in substitution for the other guideline recommendations, and in fact, avoidance of reliance on passive treatment approaches is just as important an element as avoidance of prescription opioids for medical doctors for guideline concordant management of acute low back pain.